Research in pediatric medicine has transformed what's possible. Children born with heart disease, cancer, and other serious conditions are surviving at rates that once seemed out of reach. But survival doesn't always mean children stay active, fully participate in daily life, or have great quality of life. Many kids struggle with fatigue, fear of what will happen if they exercise too hard, and other anxieties long after their initial treatment ends. Welcome to The Lead in Peds, the podcast where we highlight the breakthroughs driving pediatric research and clinical care. I'm your host, Dr. Nate Kuppermann, Chief Academic Officer and Chair of Pediatrics at Children's National Hospital in Washington, D.C. Today's guest believes that surviving a childhood disease is only the beginning. Dr. Pascal Amedro is a groundbreaking pediatric cardiologist and internationally recognized researcher who is reframing cardiac rehabilitation as medicine. He uses exercise capacity to understand how children actually live, not just how they survive. Pascal, welcome to the show. Really great to have you.
Thank you for inviting me.
So before we kind of get into the details and the science, I just want to reach out as a transplant. That is, I arrived here to DC about a year and a half ago, but just from California. So there was some culture change, but no language change. You've recently arrived from France. How has it been so far? And what's been your biggest surprise of being here in DC?
It's been great. Really, I enjoy it a lot. And well, I'm not completely new. I was here for the first time actually in the States when I was 16. I was an exchange student here. I kind of dreamt to ever come back. So the first time I came here, I had to adapt to everything. And now I'm coming here to build something. So it's very new and original, and I'm very enthusiastic about it.
You'll tell our audience, but you're trained actually as both a pediatric cardiologist and as an adult cardiologist. So how did you go from that training into the world of exercise physiology in general? Tell us a little bit about that path.
So actually, it's a little bit randomly. I was studying public health, and I was at the same time being trained in fetal cardiology. And in fetal cardiology at that point, when I was a fellow, a lot of parents were asking my mentors, since my child is going to survive, which is amazing, thanks to medical advance, what is my child's quality of life is going to be? So that was many years ago. And my mentors sometimes were struggling answering those questions about quality of life. So I said maybe I should train a little bit in the public health system about patient-reported outcomes. So I did a PhD in a lab where there were experts in patient-reported outcomes. At the time we were in cardiology, patient-reported outcomes were not considered very scientific. And in the meantime, in my hospital, we had an adult CPET lab. And I said, this is interesting. Exercise physiology didn't exist in pediatrics. So my very first publication is the correlation between exercise capacity and quality of life. So that's how it started.
Why don't you just explain to the listeners CPET?
Yeah. So CPET means cardiopulmonary exercise test. And usually you measure something called VO2 max. So the athletes know that. VO2 is maximum oxygen uptake. And it's a number expressed in milliliter per kilo per minute that relates the overall health status usually. So it's something very important. It wasn't really used before in pediatrics, but now a lot of pediatricians use this value to determine the physical capacity of a child.
One thing I forgot to comment. It's interesting. You were talking about patient-reported outcomes in cardiology when you were doing this, when you were earlier in your career. But you were way ahead of the field because even in the United States, patient-centered outcomes in medicine in general, they really didn't come to be until the last decade or two, much less in pediatric cardiology. So you were well ahead of your time, certainly here in the United States, where now actually we do, a lot of research with very patient-centered, patient-oriented outcomes. But you were doing that a long
time
I
was
ago.
Talking to my patients and also talking to experts in patient-reported outcomes who are mainly researchers, but who are struggling to implement those questionnaires into real-life pediatric follow-up. So they taught me how to make it something very scientific. So actually, as a pediatric cardiologist, I validated for the first time an American quality of life questionnaire into French. And when I was young, I thought it was just translation. Well, validate a questionnaire is much more than translation. Yeah. It's actually probably the most difficult article I ever had to write. Yeah. So it's called psychometric validation. So it's very difficult. So I was trained in that in my PhD lab, and then working at the same time on exercise physiology. But they were so close. So at that time, it was I didn't know I was doing something very meaningful. I was just interested in doing that. I was strongly supported by patient advocacy organizations too. They were really, they gave me scholarship to do this line of research also. So,
yeah, that's really important, as you know, like for folks that are doing patient-centered outcomes, having sort of stakeholder groups that represent patients and their families and whatnot. But again, we've discovered that in the United States in the last couple of decades, and you were doing that really quite early for Peds cardiology. One of the things I just also wanted to question, I remember when you gave the grand rounds when you received your endowed professorship, you were talking about you'd set up like a cardiopulmonary exercise little lab in the hospital library there.
Yes.
So tell me a little bit about that. Remind me, and what were you trying to study and do at that?
Well, at that point, I was young, and space is always an issue in hospitals. You know that. So at that time, every department had its own little library with many medical books. But the era of internet was the moment where those libraries weren't really useless. So there was this little room. So I kind of actually stole the room to put my cyclohygrometer and all the CPET equipment, and people were just looking at me like, okay, well, children of biking. So that's how it started. But actually now it's one of the biggest CPET lab in Europe, and we've actually validated reference values from a cohort of 1,200 healthy children. It's an international study with the US, Germany, France, etc. So we started small, but now it's a huge CPET lab, and we're going to replicate this in the States too.
Great. And you moved out of the library there.
Yeah. They gave me something much bigger afterwards. Yeah. And at that time, we were actually, as pediatric cardiologists, usually we also take care of adult congenital patients. So it was a CPET lab with both children and adults. So after a while, we would say, now we need two labs different. In different spaces.
And, was there a particular patient event or interaction that made you realize that survival is not all that we're looking at when we treat patients, particularly in your field in cardiology, sort of circling back to you're identifying that this is a really important way to study outcomes, but how did you get there? Was there an event that led you to that?
I really realized it was a very important issue when I was talking actually to my young adult patients. So all my ideas came from adult congenital heart disease. I said, okay, there's a new generation coming of young children. We know that they lose physical capacity, that their VO2 max decreases too fast, even though their congenital heart disease has been completely repaired. So we need to do something so that now it's not a matter of survival. Most of them survive. It's an amazing positive thing, but we need to build something more preventive. So preventive cardiology did exist in adult cardiology, general cardiology. It did not exist in pediatrics. So I said, let's try to find a program that fits children.
So kind of following with that, that sort of same line of thinking, when a child kind of clears that hurdle of the first major hurdle of treating the disease, there's obviously a sense of relief, but you realized that there was something more beyond that. Tell me how you got there.
Well, it started since I was studying exercise physiology. I was interested in the concept of physical deconditioning. There was a lot of literature about this concept in adult cardiology. So physical deconditioning, we call it the vicious circle of physical deconditioning. It starts with a chronic disease. You might be actually completely healed from this disease, but you've lost a little bit of muscles, of respiratory function, of motivation, and you do a little less exercise. So that comes from, could be an adult cancer, it could be any chronic disease in the adult population. And then you do less exercise and you take the elevator instead of taking the steps, and you do a little bit more less sports, etc. So this vicious circle is very asymptomatic for a long time. So my question was, does it occur early in children? And actually it did. And it's even more asymptomatic. If you have a congenital heart disease, you're repaired when you're neonate. Well, statistically, when you're 12 years old, that's the mean age, you start to decrease progressively your VO2 max, your exercise capacity or aerobic fitness. But you don't know about it. The family doesn't know about it. No one knows about it. And then many years later, when you're 30 or 40, even with a very simple congenital disease like a hole between two ventricles, which is called VSD, ventricle septal defect. This is a very simple congenital disease. Adults who are in the fourth of their decades of age have a very strong physical deconditioning, high cardiovascular risk. So I said, okay, let's start something preventive when they're younger. So that's what I built, this program that is a preventive cardiology program when they're young. And that was the concept of my research.
Great. So tell us a little bit about the outcome, the measures to measure these conditions. It sounds like traditional measures were not really good. And you talk about VO2. Why don't you explain us to our listeners that what is VO2 and the other measures that you use that identify this deconditioning that traditional measures have not been able to?
Yeah, so let's make it simple. If you take a young teenager, a male teenager, the normal VO2 is 47 per milliliter per kilo per minute. That's the normal value. If you lose 3.5 milliliter of this value, which is a very small number, statistically, you have a higher risk of morbidity and mortality when you're an adult. So that's the threshold value. And then there's another second number that is very important. It is the moment when you're doing an exercise test and when the exercise becomes unpleasant, when you have shortness of breath. This is very subjective. If you want to measure this physical deconditioning objectively, that's what we call the first ventilatory threshold. You measure it on a curve directly on the equipment you're using to do a CPET, to do an exercise test. So this first ventilatory threshold, if it occurs too early during your exercise test, it means that you probably have physical deconditioning. So usually we use this value to actually prescribe exercise when someone has an important physical deconditioning.
So my next question is, again, you're a pediatric cardiologist and an adult cardiologist, but the tools that you're using, the things that you're measuring, you realize at some point that, this can extend beyond cardiology to the evaluation assessment of children with other diseases, chronic diseases. How did you get from cardiology to those other diseases, and where are we in that?
Actually, my colleagues reached out to me. They said, your program is amazing. It's a preventive cardiology program. We call it quality rehab for rehabilitation and quality for quality of life. So my friends from oncology first reached out to me and they said, there's a lot of literature in the adult cancer population where, for instance, if you do rehab after breast cancer, the mortality decreases. So they were saying maybe you should evaluate those children in the childhood survivor population and do CPET, which I did. And I did for all the other diseases, asthma, sickle cell, cystic fibrosis. And that was very funny because we thought we had prejudice. We were wrong about what we thought the results were going to be. For instance, we thought the CHD, the congenital population, was going to be the worst one. Not at all. Only 20% of my cohort of children with CHD had physical deconditioning. It's almost 40 to 50% in the childhood cancer survivor population, even though they had no cardiac problem and they were in cancer remission. And we just finished a study in the chronic kidney disease, it's almost 100% of them.
Wow.
So it's a never-ending story.
Yeah. It's funny. Actually, I have to tell you, Pascal, and I'm sure I mentioned this to you. I was so excited when I heard that you were coming here because, I have a good friend in California. She's an exercise physiologist. I've, introduced you to her. She doesn't have formal scientific training like you do, but she runs an organization. It's called Cancer Champions. Her whole thing is working with adults either who have cancer or have recovered from cancer around exercise because, it's really very powerful. And I was wondering here at Children's, do we have something like that? Then I heard that you were coming, and it was really great to see all the programs that you're conducting outside of cardiology. And I think, I mentioned to you, and some of the listeners will probably be aware of this, but this friend of mine, she mostly works with, cancer patients and cancer survivors, but she has a client with sickle cell disease, and she works very closely with hematologists. I think they're at Mass General, where this person is followed. But she helped her become the first person with sickle cell disease to run a marathon. They ran the New York Marathon. It was in People magazine. But just highlighting the power of what you're doing and how it extends beyond cardiology and to not just adults, to children as well. Because it seems like things always come second to children, right? We figure things out in adults and then it comes to children. But I love, sort of having the pediatrician's lead, so.
Yeah, and actually, we always think it's more difficult in pediatrics. Doing both, it's actually easier to run those trials in children. The family is supporting the program. Usually the other colleagues from oncology or other specialties really support those programs. And the risks are extremely non-existent in children. I would be very comfortable in promoting my program, my rehab program, in a child with a sickle cell.
It's interesting. You said something that I have been a strong advocate for my career. When you here in the United States, we write for NIH grants and whatnot. Historically, they've considered children as a vulnerable population, and I understand because people that don't work with children, they think they're delicate and fragile. The problem is then they don't want to fund grants because they say, "Oh, children, they're too delicate." But we need everyone to get over that because, of course, we have to do the same, even more studies in children than we do in adults. Again, with the appropriate guardrails and using patient advocacy and whatnot. But it's been something that we've had to overcome here in the United States for funders that they consider children a vulnerable population when we consider them, no, we can't improve their lives unless we study these conditions and figure out ways to make them better,
Yeah, I fully agree. And we have the same issues in Europe.
Yeah.
Actually, a lot of things. This is a big surprise for me. I thought I was going to discover a very different environment or rules, or microscopically, it's the same. Between Europe and here, I would say really doing research there or here, or we struggle for the same things and we find solutions mostly the same way.
You've talked about in the past about the 3 pillars of your program. Do you want to just describe what those are to
Yeah, so it comes from the fact that usually people think that cardiac rehabilitation is only exercise training. It's extremely important, but it's not enough. I looked at what the adult cardiology studies showed, and in adult heart failure, they mostly rely on 3 pillars: exercise training, patient education, and mental health support. So I said, okay, let's not reinvent the wheel. If the randomized controlled trials in adult cardiology are positive when you use those 3 pillars, let's try to adapt that to pediatrics. And, cardiac rehabilitation in adult population, it's the best drug. It's the highest level of evidence. Why wouldn't it be the same in pediatrics? Fortunately, we're not going to use mortality as an outcome as the adult population would do, but we have quality of life, which is a serious, relevant outcome. So that's what I did. I kept the idea of the 3 pillars. I transformed that. I adapted it to pediatrics. But I used another primary outcome. My primary outcome was quality of life, and the secondary outcome was VO2 max. And the third outcome was mental health. That's actually the most difficult part for me. I'm not a mental health specialist, so I collaborate with neuropsychologists, psychologists, and they help me build tailor the mental health support component of quality rehab for different populations. So we have different trials depending on the population. And patient education, it's fundamental. So I just recruited an advanced practice nurse here in Children's National. She's going to improve this specific section on patient education. We started with a few people with us in the team, and now we have a huge international team to improve patient education, digital health, digital platforms. So this is extremely important. And specifically, I tested a patient education randomized controlled trial just to test this component, and just this component also improves quality of life.
So I want to highlight one thing for our listeners of what you're talking about. And besides the great work, that you are doing yourself, it's really the magic of collaboration. I say this all the time, around my research table. It's not, I'm a pediatric emergency physician by training. It's not 7 pediatric emergency physicians sitting around the table. It's me, and then there's a basic scientist and a knowledge translation person and a patient advocate and an IT person. People looking at things with different lenses, with different areas of expertise. That's where the magic really happens, right? And what you've described in your team and your collaboration, that's what you've really put together. And it's great when you bring somebody in that has some expertise that you didn't have. You think, oh my God, that would be great for my program, So,
yes, that's exactly the vision I have too. And sometimes collaborations start just randomly because you meet a colleague at the cafeteria, and then from a small talk, it becomes a huge 2 million grant.
Right.
And that's actually some of my trials started with a neuropsychologist. She said, I'm doing the same thing for neurocognitive problems. You're doing physical. Let's build something. And now it's called Quali Neuro Rehab Trial. So that's exactly how it starts.
So tell me a little bit about the Quali Rehab program that you started, and let the listeners know.
So I started, actually, to be honest, before COVID. I won a European grant before COVID. So it's this preventive cardiac rehab program with those 3 pillars we mentioned before. Originally, I enrolled teenagers and young adults in this trial with congenital heart disease. Everybody thought I was crazy. Everybody thought it was going to be dangerous. That was 2017. It's yesterday. And we were doing the hybrid concept of my program is that we don't replace human interaction by remote or telemedicine. We add it to existing healthcare interaction with patients. For instance, we have exercise trainers who actually go to the patient's house to deliver 1 hour of exercise training a week. And the second session during the week is doing remotely. So that's the hybrid concept. Because at that time, I was extremely interested in telemedicine, because even before COVID, I thought it could be very good for our patients. They don't want to go to the hospital. So that's why I started this concept of hybrid rehab. And it did work. The association between center-based rehab with human interaction and home-based rehab also with human interaction, plus the digital platform in the remote sessions. That's, I think in English you said the chicken soup.
Yeah.
Maybe that's one of the solution. So that's the first randomized controlled trial in pediatrics that demonstrated a positive efficacy on the primary outcome. Of course, the primary outcome was quality of life,
right?
But it also improved the VO2 max. I told you previously that if you lose 3.5 milliliter, it's not a good thing. In this trial, after the 3-month program, they increased by 3 milliliter. It's not 3.5, but it's not that bad. And we're going to do better now, because at that time we were cautious. We were prescribing moderate physical activity at the threshold level I told you before. Now we're doing HIIT. For those who are familiar, it's high intensity interval training. So we're actually doing this now in children with single ventricles.
Wow, amazing. And these were done, and again, all our listeners, just want to put it out there, the randomized trial is really the gold standard, that way that we study clinical interventions and stuff. So what you described there was tested through randomized trial in France and other parts of Europe.
Yeah, so it started in France,
Yeah.
and then now it's European program. But since I'm here, we're going to start a new randomized controlled trial in the childhood cancer survivor population. So that's on the list. The ethical question I have now is, am I allowed to have a control group which doesn't receive intervention? Is it ethical considering cardiac rehab is the best drug now? I repeat this, it's the best drug we don't use enough, cardiac rehab. Is it ethical to have a randomized population where the control group receive no intervention? So we might have to find of new ways to do research in my field.
Are the skills that children learn in quality rehab, do they sustain beyond the end of the program?
So in the first trial, some of the outcomes were positive after 12 months. So the program lasts 12 weeks, so 3 months. But the primary outcome and the secondary outcomes were measured after 1 year. We took a risk doing this. It's not usual. Usually in those similar trials, a lot of colleagues measured right after the intervention. I said, no, children come once a year to the hospital. Let's take a risk and let's try to measure those outcomes at 1 year, which is not a lot, but it's still considered a long-term assessment.
That's long for
So
me.
the trial is positive, so that's good for the publication. But if I have to be honest, I would like to do better. The quality of life increase was statistically significant, but it's only 4 points. We need to do better. The VO2 max increased immediately after the intervention, but started to decrease. So we need to work on past rehab, which we're doing now here in children's. The mental health also increased, but probably could be improved more. The body mass index decreased. That was a surprise, actually. After 12 months, that remained. And what was interesting is that thanks to patient education, all the questionnaires we gave them a year later about disease knowledge, patient autonomy, that remained positive.
Wow.
So that's interesting. So the message is we did well. Probably that was the first trial, but we're now running new trials where we want to increase the magnitude of the efficacy of this program. And we want to tailor it also. You know, research sometimes very strict. Now we're going to try to tailor this program based on the baseline assessment of our patients.
And just throwing it out there as an investigator, are there perhaps more brief interventions that you can do ongoing? I mean, the big intervention, over this 12-week period, I don't know, to sustain the effects for longer, is that?
So we're hesitating in what we should do. Should we have physical interaction? Should we have the children come to the hospital for like check-in, regular check-in with an exercise trainer, with the nurse, etc.? Or should we do it completely remotely? So ideally, we should go to the house. That's what we should do. So we are actually doing it for the exercise trainer. So we're working on that, but past rehab is extremely important.
Well, let me ask you, it's a super interesting question, this issue of when is something really considered so standard that you really cannot randomize to placebo or nothing. As an aside, do you work with an ethicist or do you consult ethicists for these sorts of trials?
Yeah, so I was myself member of a pediatric ethical committee in France. So that's always the questions we have. The good thing is to have a lot of money when you receive funds, because the solution is once the trial is finished, the control arm that received no intervention, if you have enough money, you could give them the intervention or a light version of the intervention. So that's what I'm doing now. And I will probably be able to do this in Children's National because I'm very lucky to have been to have received a significant fund from the Dunn family during my professorship.
By the way, and I'm just going to highlight that it is, again, the power of donors. I mean, the Dunn family is really allowing you to take all what you're doing and also to a new level. So as we kind of we're sort of wind down, let me just ask you kind of the 30,000-foot view, given your tremendous expertise and history, and we're so excited, by the way, you're at Children's National. What do you envision, like over the next 5 to 10 years, what would you think would be the ideal pediatric rehabilitation program for all children with serious chronic, illnesses? I mean, what do you project to the future? Where are we going in terms of that?
So clinically, I think we need now in pediatric hospitals very big preventive teams. Prevention should not belong to subspecialties. We should have really important preventive teams with academic research, with clinical expertise. So that's the first part. The second part is public health, is how can we have those programs covered by health insurance? Currently, neither in Europe nor here am I able to bill the home-based component of the program. Everybody is saying prevention is important. The health insurance has to pay that. So I would just, that's 2 points. Building preventive structures, real preventive structures, big staff in pediatric hospitals across all childhood diseases. Even though I'm a pediatric cardiologist, I would be ready to abandon my first job to really work with a team of preventive people. And the second thing, public health and health insurance. That's two, there are many things to do, but that's, I think, two very important things we need to work on.
Yeah, interesting. So the last couple of questions I'm going to ask you are one that we can't ignore, that we have so much digital technology around us and AI and whatnot. How do you foresee that being part of your programs moving forward? And then finally, what is your what excites you most about programs that you'll build specifically at Children's National?
So for the first question, I started without any digital platform. I just used Zoom. Now we have a multidisciplinary digital platform. It's a wonderful tool. A lot of people like human interactions, but a lot of families and children prefer the remote. So we tailor, thanks to those tools, we tailor the rehab, and that's really helpful for adherence, patient adherence, for equity. So really, I think digital platforms have to exist in the environment of prevention. And also, we have a digital platform that actually calculates everything, that helps me prescribe the dose of physical activity. And at the end, if we collect a lot of data, probably those tools will be able to advise us and say, well, considering this specific patient, this specific environment, this specific needs, VO2 max, quality of life, and disease, maybe you should prescribe this type of rehab. So that's what I see in the future. And the second question was about what is going to be new here in Children's National.
What are you most excited about sort of starting up here?
So what I like here is the possibility to work much more than I ever did before with other colleagues. In Europe, I did it, but from a research perspective. Here, I have the feeling that it's going to be also in real life. I've met with mostly all the subspecialists within a short period of time. They're very enthusiastic. They're already referring patients to our CPET lab and our exercise clinic. So that's the first thing. The second thing is that we're going to try to do both clinical research and real life in this unit. So for instance, we've built a little room, we call it the hybrid fitness room. People are going to come to the hospital in this room, and people want to be remotely connected to the digital platform. Well, for the first time, so we have the room now, we have a big screen on the wall, we have all the equipment, and we hope to have a group of children. Some of them will be at the hospital, some of them will be home. We're going to test the group interaction, the group effect, because I think that's very important. And we're going to try to do something that I've never done. Maybe we're going to forget which disease they have. Maybe we're going to have a child with a kidney disease and a child who is in remission from cancer and a child with a congenital disease. We don't care about the disease. They have the same needs. They need the same program. So that's my dream. And I think here it might be possible. When I was interviewed here, I had the feeling that, hospitals are usually organized in silo. It was not really the case here. That's actually why I was interested by coming here.
So Pascal, tell me, what is your vision for pediatric rehabilitation medicine, specifically here at Children's National in Washington, D.C.?
Well, considering that there's all of my colleagues here are very enthusiastic about this program, I think we should build something very new, very original. We're working on it, probably a CPET lab, shouldn't be a CPET lab just for cardiologists. Probably we could run a CPET lab with the expertise from other specialists, for instance, lung specialists. They have a room in this lab. So I think we should probably open the space for other colleagues in the assessment. Psychologists, behavioral medicine should be part of the assessment. So I think here in Children's National, I have the feeling that the fact that we're not working in silo, this is going to be possible. Same thing for the intervention. I'm a pediatric cardiologist. I have a vision of cardiac rehab. I think we could improve with this program with the help of my colleagues here, and I'm sure we're going to do that.
Well, that's great. And I think with that, I think it's a good place to stop. And let me just say, Dr. Pascal Amedro, first of all, thank you for joining me on the Lead in Peds. It's been really fun. For me, I always learn so much stuff, and I've learned a ton from you. Thanks for all the great work you're doing. And again, I welcome you to Children's National. It's great to be your colleague there.
Thank you, Nate.
Thank you to Dr. Pascal Amedro for joining us today. In this episode of the Lead in Peds, we explored why survival alone is not enough and how pediatric cardiac rehabilitation can help children move beyond survival towards fuller, healthier lives. Dr. Amedro's work reminds us that cardiac rehabilitation is about more than fixing a heart. It's about restoring function, confidence, and quality of life. Thank you for listening. Be sure to subscribe and share this episode with anyone interested in how Children's National is leading the future of pediatric research, innovation, and care.